I'm going to hand over first of all to Ian, who as Deputy Secretary of Prime Minister and Cabinet has a special responsibility, it was announced earlier in the year when he was appointed, to reconsider the Closing the Gap strategy, and he's thinking about ways to revise the Closing the Gap strategy to take into account many of the points that have been made here and elsewhere. There's concern with what's called the deficit narrative or the negative narrative, although I think we shouldn't throw the baby out with the bathwater. It's important to remind the nation about the high incarceration rates, the high levels of violence in some areas of Australia, the very high levels of removal of children from their families under notification and substantiation in child protection systems. But we need to measure our successes as well. So Ian, over to you, please.
Okay, Marcia, thank you. And I'm going to have to disappear at some point because I've got to catch a plane. So if I run out of the room, it's not because I disagree. I just need to go. So I'm going to talk about 5 minutes around Close the Gap and what we're hoping to achieve. It touches on some really important elements of this agenda, but not all of them. So I'm not going to talk about the Indigenous data governance strategy. That's quite important, but that requires another conversation. So 10 years ago in 2008, Australian governments agreed to 8 national targets. This is called the Close the Gap. They include targets in relationship to employment, schools retention, life expectancy, and so on. Next year, 4 of those targets will expire. So this gives us an opportunity to look back over the last decade and to start to rethink the role of targets in national policy, but also to actually set some of the broad elements of the policy agenda for the next decade. Now, COAG is what I call macro policy. It's using big policy levers in order to really drive system change down through Australian governments. There are a couple of key things that I think are learnings out of the COAG process. The first thing is that the target's been very useful in bringing data into decision making and resource allocation in public policy. Second thing is that having the 8 national targets actually brought the Indigenous policy agenda back to the centre of the national policy debate. And if you witness the kind of annual Close the Gap statement, you'll get what I mean. It's actually front and centre in national government. But there are a number of things that I think we could learn from the approach, and I want to say a little bit about some of those things. First of all is that it's largely a deficit-framed narrative. Now, I want to come back because I think Marcia's right. We need a nuanced approach, but I want to explain what that might look like. The second thing is that the first set of targets didn't get the balance of science and politics right. When we're setting targets, there's a particular methodology in public policy we use. The key thing is they need to be achievable. And that requires an understanding of data trends and a fine approach to thinking, if we're going to hit here in 10 years, how can we do better? But making sure that that's achievable through investment. One of the trouble with the current set of targets is that even though across all the 8 targets have been trends in the right direction, the annual report will say we're not on track. Now, the problem with that is that creates political paralysis. People think, oh, okay, so we're putting all this money into Indigenous affairs, but we're getting nowhere. Whereas, in fact, we're actually moving. And the problem was the original set of targets were set as guesses rather than a more scientific approach to actually setting where targets do. And that's particularly true across the Federation. What is achievable in schools retention in the Northern Territory is very different to what's achievable in New South Wales. And yet we set a national target that makes the Territory walk up a wall and New South Wales government kind of dawdle along because they're getting there anyway. So we've got to think about how we use national targets in a more clever way. The other thing is that targets need, and this is a principle that the Australian government is advocating through the process, targets need to be aligned to the level of service delivery responsibility. Targets need to drive change. At the moment, the targets are actually Commonwealth targets. jurisdictions actually don't own targets. So that means that a lot of the things that the Commonwealth reports on actually the levers for change in the jurisdictions. This is a very important consideration for when you're thinking about targets in relationship to justice. State governments run prisons, yeah. So a national target is not going to drive action at a state and territory level, and child protection. So the important part of the thinking is about how do you set targets that align to accountability and accountability across the system. And the third part of that is where is Indigenous Australia in this? So one of the important principles that we've set in the renegotiation process, which will take us another 6 to 12 months, is that there are three parties in this negotiation: Commonwealth governments, state and territory governments, and Indigenous Australia. And that's very critical when you actually come to think about how do you use data and target setting to kind of drive the big system change over the next decade, particularly around local decision making and regional governance. Most of the gap, if you want to talk about it, can be changed, but it's going to require change on the ground. It's going to require decisions within families, within communities, within individuals to change behaviour or do something differently. That sort of decision can't be imposed by government. Government services play a really critical role in enabling that, but at the end of the day, these are life decisions that need to be led locally. So collaboration and partnership is fundamental to this, and there will be a process of engagement which will go over the next 6 months, which will start next week or the week after. We're just waiting for one more jurisdiction to sign on. And then the other part of the thinking is that we need to bake in Indigenous engagement into the COAG system, which is an intergovernmental system. So how do we bring Indigenous leadership into the top table with First Ministers, into a conversation, build the kind of relationships at that level, and then also through the principles of implementation through local decision making and regional based decision making. So can I talk about? I'm going to talk about two more things. The first thing is how do you build a strength-based narrative? So this is actually quite challenging. As Marcia really pointed out, it can't take the eye off the stark disadvantage in Indigenous Australia. You can't not lose a focus on that. That's one of the reasons why we need targets. So one of the challenges is to think about building a different sort of narrative that's probably more nuanced, and there's probably three elements to this. One of the things is on the table is, do we use Close the Gap as a frame, or do we use another sort of narrative to kind of frame aspirations? Through our Indigenous Advisory Council, we've been building a narrative that we want to test through the engagement process. And that narrative has a number of elements. One is an aspiration for prosperity. We started off with wellbeing, but the decision was to actually shift to prosperity to really strengthen the focus on economic development and as a part of the change agenda. I'll come back to that. The second is to say that the aspiration for enduring and resilient Indigenous cultures, at the centre of this is a real aspiration. We need to bring that into the centre of the narrative. But it's framed in a very particular way. It's an understanding of culture that is changing, that is dynamic and it's resilient, but it's also a culture that's open to the kind of ethical conversations that you have at a local level, within your family, within your community, within your local mob, to say what are the behaviours and values that are aligned to that aspiration for thriving, and aligned to that aspiration of wellbeing, and aligned with that aspiration of prosperity. So it's trying to talk about culture in a dynamic way, but also one that is also open to change with time, but open to change through leadership. I did have a PowerPoint, and it would have been easier if I could have shown this slide. The framework that we've been developing is an opportunities-based framework. So it's saying that we need to build targets which flow onto investment and policy agendas that build opportunities. The sort of range of opportunities and capabilities that are needed in order for individuals to kind of lead the life they value. It's very much a SEND framework, for those who are familiar with that. But build the life that they value around the choices that they want to make. So this doesn't predetermine a direction. It allows for people to say, the thing that I value most is to be working on country as an Indigenous ranger, or I want to be an accountant, or I want to own my own business, or I want to participate in Australia, in a society in a way that's meaningful to me. So it doesn't set a direction, it creates the opportunities and capabilities that are going to enable that. There are 4 domains, broad domains that we're testing. One domain which is around individual capabilities, education across the life course, early childhood and through to tertiary, and health outcomes. The second, an environmental domain, which captures those opportunities around realisation of native and sea rights, native title and sea rights. Community domain, which looks at the things between us. Have we got the opportunity to grow up in a safe and nurturing environment, a safe community free of violence? And then again, the economic domain, which is new to the agenda. Do we have the ability to create our own business, pass on income to the next, wealth to the next generation, and so on. So this opportunities, it's kind of that broad framework that we're trying to build a strength-based narrative. Second thing is to also think about across the range of measures, we need a mix. We need a mix that shine a light on the strengths. So, for example, show the growing number of Indigenous Australians in tertiary education or completion of tertiary education, or the growing number of Indigenous businesses, whilst at the same time also measuring life expectancy and issues around justice targets. And then the final thing is to think about, and this again with the strength-based narrative, is that how do you measure? What's your choice of measurement? Do you measure poverty or do you measure growth in median wealth? Those are kind of the questions we need to go through and think about how do we build a more nuanced narrative that carries focus on the things we need to focus on while shining a light on success. Now, I won't say much more. Having said that, and I said this the other day, a strength-based narrative doesn't actually mean that people will see the strengths. So one of the, and the analogy I use is that I think the strength-based framework is like using a full orchestra, piccolos, flutes, first violins, drums. Unfortunately, when we play the full orchestra, some people only hear the drums. So there's a much bigger agenda around how we shift the ways in which and Indigenous peoples are seen in this country so that they can actually hear it when we're playing that full narrative. So 2 hooks in this. That's the framework. The other hook, and this will be built into the implementation principles, we think that the future is building local and regional decision making. That's a 10-year agenda. There are some communities that are already way ahead. There are some communities that are just starting on that journey, and we need to work with communities and at multiple levels of development around how we build those capabilities. That has fundamental challenges to how government does business. The second thing is how do we get the data platforms in place so that when people are making those local decisions, they have the information in front of them that they need. And that, again, is a fundamental challenge to government and will probably take a good 10 years to realise. So, thank you. So thanks, Marcia. So that's a bit of a high-level summary. It's going to be out there, and you'll probably be able to comment on some of the thinking around this in the next week or so through our public engagement. Sorry. I think it's...
What is the question, sorry?
No, just... I'm mentioning a timeline, now being very vague. We're just waiting, this is a COAG process, so we've got to get all jurisdictions to agree to it. We're just waiting on the last jurisdiction. I'm hoping it'll be in the next week and a bit. It's that close. Yeah. Cool.
Okay, so just because you missed some yesterday, Ian, and we know how busy you are, and thank you so much for that excellent update. Perhaps, John, you can update Ian on how the, for instance, the Minister just, wrote to all the members of the Advisory Committee to the Australian Institute of Health and Welfare and what the consequences of that are in dismissing you all out of the blue. And I think a number of committees have been dismissed. But I don't expect you to respond, Ian, but I just want you to know that that all of these committees have been dismissed, and I don't know the exact details, but perhaps you know more than I do, John.
Maybe not, but I suppose before getting to that bit about where the story's ending up, which is not good, I think the first part of the story in terms of governance of health data was a very, there's a very good story, and we're in a period now where gains that were made are being lost, very, significantly lost. But I think, so the original part of the story was, I think, when the Aboriginal Health Services and their peak bodies like AMSAN and NATCHO advocated for the transfer of health from AIATSIS to the Commonwealth Health Department back in 1995, there were 4 main aims, and one of those 4 aims was improved data. So it was actually Aboriginal organisations, health services, that realised we had to have better data. And that happened very quickly because the newly formed AIATSIS employed John Deeble, who was the father of Medicare, and some other health economists, and some of the first data we got, because AIATSIS only had $54 million for Aboriginal health services back then. The big money was Medicare, which was $6 billion, and the PBS, which is $3 billion. And there was this myth, like what Marcia said before, $30 billion a year being spent on Aboriginal people. Well, back then the same myth was being thrown around. Everyone thought huge amounts of money were being spent on Aboriginal health and no gain. So John Deeble set about showing that for every dollar of Medicare spent on non-Aboriginal people, there was 27 cents being spent on Aboriginal people, and for every dollar of the pharmaceutical benefit scheme being spent on non-Aboriginal people, there was 21 cents being spent on Aboriginal people. So on the back, that was the first lot of data we got. And then that drove policy change. So July 1, 1996, the Howard government gave salaried doctors in Aboriginal Health Service access to Medicare. And then July 1, 1998, again, the Howard government, Minister Woolridge gave remote area Aboriginal people access to the PBS through Section 100. So Section 100, because of that, we've got greater than parity. Now there's more than $1 access for Aboriginal people compared to non-Aboriginal people only in remote areas. It hasn't helped in rural areas and hasn't helped in cities. And in Medicare, that data was collected for about 10 years. It hasn't been collected for a long time now. I don't know whether Ian knows the figure, but last time I saw it, it was about 50 cents. Aboriginal people have got up to 50 cents in the dollar, but that's nowhere near parity. So the first lot of data that was driven by Aboriginal Health Service was data about funding, and it made a big difference. AIATSIS was worth 70 million in the first year. It's now worth 850 million a year, and Medicare and PBS has come to Aboriginal people. There's been a huge increase in funding for primary health care. So that was the first thing. The second lot of data we needed, because we were arguing we were very poorly resourced, we needed a lot more money, and Ian was in AIATSIS in this era when the Primary Healthcare Access Program got started, which gave us a lot more primary healthcare money, but we realised we had to, if we're going to get a big investment, we had to look at what services we were going to deliver and how we were going to report to demonstrate that that investment was working. And again, it was Aboriginal Health Services that led the development of key performance indicators. So the Cooperative Research Centre, which is controlled by Aboriginal people in the Northern Territory, undertook a research project which was done by a woman called Pam Gollo, who's not with us anymore, but she came up, and that was led by Aboriginal Health Services, guided that. There were Aboriginal people on the board of that institution, and it was governed by the Northern Territory Aboriginal Health Forum, and that came up with 45 indicators, which eventually led to the 19 KPIs in the Northern Territory, of which 12 were clinical and 7 weren't. So those original KPIs came from, again, Aboriginal leadership from the health sector. It was driven, and that's not so much where we ended up with the end KPIs, the national KPIs, but that's where we ended up in the Territory. And the data governance for that, there was a data warehouse established, an agreement with AMSAN. So again, that was a good story. And then we got access to health status data, social determinants data through the Health Performance Framework, which is all very important. And we set up structures like AIATSIS, which NATCHO chaired. So you had the Aboriginal organisations at every level. AIATSIS was chaired by NATCHO. There was the National Council for Aboriginal Children and Health, which advised the Minister. That existed until the Abbott government got rid of it. That's the first thing they did. They got rid of, it became known as the Aboriginal Children and Health Equality Council, Equity Council by the end. It changed its name a few times, but it was basically a peak body advising the Federal Health Minister on Aboriginal health, and NATCHO chaired it. But they got rid of that first, so that went. And it sort of went without too much of a whimper, which is a bit unfortunate. Then recently, the assault on... These structures were all, at every level, There was governance, you know, at the state level through the forums. There was resourced Aboriginal leadership through AMSANT, affiliates, NACHO. They sat on national structures, state structures. There was agreements. This is over health data. But now we're seeing, you know, as we talked about yesterday, Negatsiab was just cut with, without explanation a couple of months ago. And that's
Abolished.
And that was that's an RMAC standing committee. That was the highest level committee. There's another committee still that's called the National Aboriginal Child and Health Service Data Advisory Committee, which still exists. But, you know, at that level, if we didn't get agreement, we always knew we'd get a second bite at the cherry at Negatsiab. And you could, you know, by and large, RMAC listened to Negatsiab. There wasn't many examples where RMAC made decisions that weren't supported by Negatsiab. So getting rid of it, we're losing ground that we had in data governance over health data. And, you know, the devil's in the detail. When you develop performance indicators, like, say, take the 10 COAG closing the gap indicators, one of them is preschool. Now, we know 2 years of preschool is vital for health development. It's a $16 return over a lifetime for every dollar spent in terms of preschool. So there's an indicator on attending preschool. So in the Northern Territory, 92% of Aboriginal children attend preschool every year, and that's in the report. And you think, gee, that's good, except it's not true, because what they're measuring, if you think a preschool is an institution that has a preschool teacher with a university qualification in front of it, that's not what's being measured. What's being measured is children who attend some sort of preschool program, and that's very different. You might have people in a remote community, kids in a remote community attending a classroom that's run by a local community person. That's a preschool program, and that counts as a preschool. So the actual attendance and to work out the attendance at preschool, again, the education departments don't know the denominator. We talked about how important it is to know the denominator. So in Alice Springs, they thought all kids were going to preschool, and Congress said, well, there's 160 kids aged 3 and there's 160 aged 4, and the department said, no, there's only 100. And so in the end, we had to go in and show them these children existed. They were on our database, and sure enough, there's 40 or 50 children not attending preschool, and there's not enough places for them. So there's all sorts of ways in which I think there's been some really good developments in health and control of data in health and the use of data to lead policy change. But some of those gains are being lost, and we need to be very careful as we move forward that we try and maintain and build new national structures. And with this COAG process, it could be good, but we've got to be involved in it at every level to make sure. And whatever indicators they come up with, we've also got to know what's the numerator, what's the denominator, what's actually being measured here, what's being reported on. I'll leave it at that.
Thanks, John. That was a bit of an alphabet soup, but I'm sure people from the health sector here followed all of that. Blah. Look, you know, I'm vaguely aware of it. Now, Ian, I'm very mindful that you have to leave. Can you just give me a hoy?
I'm going to have to go in a sec, but I just might say there's a couple of opportunities here. So John's absolutely right in the narrative around the development of really robust structures around data in the health sector, and that has a 15-year history. I don't know about the RMAC decision, the Australian Health Ministers' Council, but there is another opportunity, and one of the reasons why we are leading a COAG reform is because it's through First Ministers. It's not through the line ministers. It's not through education, it's not through health, it's not through Aboriginal affairs. It's actually First Ministers. And there's a particular...
What do you mean by First Ministers?
So, Premiers.
Premiers.
Premiers and Prime Minister.
And Prime Minister.
So
Okay.
this is about trying to bring the agenda back to the centre of government, not to the line or to the periphery of government. So there is one opportunity here is we can actually, because one of the problems is that a lot of what is health data is also educational data, is also related to other systems, and we probably don't have the people around to have those sort of robust advisory structures across each sector. But what we can do is think about going up a level. You know, so there will be a process for monitoring outcomes on COAG. So maybe there is a data advisory structure of some form at a more senior level across COAG. And I forgot the other point. But my mum said it must have been a lie. So yeah. Look, and I think the other point I was going to make is that Data governance requires us to be everywhere. There's not one part of the system. And I think I'm really intrigued by thinking through Tahu's suggestion about what are the intermediary structures between community and government that actually might build those kind of networks in different ways, because I don't think that what you need is another 25 advisory system structures, particularly if they're not going to make impact. So think about governance. I think our challenge is about governance in a really innovative way, about how it is that we create meaningful control and meaningful impact through data. So I'm going to have to leave it there. I feel deeply apologetic.
We're very grateful for your time,
Yeah.
given that you're a very senior person in the Australian government, and you've been very forthcoming with the latest developments in government, in the Australian government. So thank you very much.
Yeah, thank you. Thank you, guys.
There's a little...
Can I also say that this is absolutely fabulous. One of the things that you need, I think is really important to drive change, is to build the social networks, to build the professional networks. I can do so much within government, but I need this sort of kind of social network to actually kind of be prompting. You know, otherwise you're just talking to yourself, or you seem to be. So I think this is a really and I'm just been really stunned by the quality of the presentation. So absolutely well done. Thank you.
So, does anybody want to follow on from that? Perhaps Neil, given that you're the HealthInfoNet man for what, a quarter of a century?
The HealthInfoNet's been around for 20 years or so. It started,
20 years or more?
Yeah, it started in 1985 with a fellow that many of you will know, called Neil Thompson, who did a fellowship at the Aboriginal and Torres Strait Islander Institute. And his goal was to bring together all the Aboriginal and Torres Strait Islander health research. And out of that grew the HealthInfoNet. And now we're a reasonably massive resource. We've been going over 20 years. We receive around about 1.2 million sessions or visits a year to our resource. And we did a recent survey of our users and found that 98% of them were pretty satisfied with what we're doing. So we think we're on the right track, but we by no means want to be complacent. But what I want to do is position us outside the primary data collection area. We're in the space that Rom referred to yesterday, and that is the knowledge exchange space. And that is sort of getting the research rubber on the road. And I think this is a really important area for us to think about in terms of data sovereignty, because, as Tahu said, the amount of information that we're receiving. There was a survey in 2005 that said you'd need to be reading 19 original papers a day in biomedicine alone just to be keeping up, growing at X%. So I sort of extrapolated that like a good quantoid. And now in 2017, we're up to about 42 original papers a day in biomedicine. Now there are 40 or 50 health topics in Aboriginal and Torres Strait Islander health. So now we're up to about 1,500 papers a day. So getting data sovereignty to cut through is really important. And I think that's the area that we're in. Now, the problem with knowledge exchange research is that it's fallen foul, and some Indigenous researchers and scholars in knowledge exchange in Canada in particular have noted the theory, methods and concepts of knowledge exchange have fallen foul of the same ills that beset primary research during the period of colonisation. So we're repeating the ills of the past. So my exhortation would be that if we're going into the area of data sovereignty and data ownership, that we develop the theories and methods and concepts of knowledge exchange in that space in a culturally appropriate way. And that's what this whole couple of days has been about. And I must say my thanks to Marcia and the others for inviting me along. It's just been an awesome experience to hear what's being done. And at the HealthInfoNet, I've been frantically emailing myself, so we're going to get on to Jason and get his story so we can showcase those stories. And I'm thinking seriously about, do we need a data sovereignty warriors page or something on the HealthInfoNet so that we can showcase the local level data that's being generated, honouring the principles of co-construction, co-design, ownership, stewardship, leadership. And so these are the things that have really struck me at the HealthInfoNet. So I'm tremendously excited about the potential and the possibility. And again, I thank you so much for the opportunity to be a part of the conversation.
Neil, that's a fabulous idea, a data warriors page. What a fabulous idea.
It's kind of, it struck me, I email myself so I don't forget to do things. So when I get home, I find all these emails to myself and I'm like, don't forget to talk to Jason. Oh, don't forget to talk to Sky. Oh, don't forget to talk to Eunice. And I've just been emailing myself constantly for the last couple of days. I do think it's important. And we, with 1.2 million visitors a year, now it could be 1.2 2 million people, individuals coming, or one person coming 1.2 million times, or somewhere in between. But we get a lot of traffic, and we do get a lot of our data from the more traditional sources, ABS, AHW, and all of those other sources of data. But, and we have such a dearth of local level data around this notion of sovereignty that I do think it's worth highlighting. I think it's such an important conversation for us to be having, and we would be delighted to have that level of data available and make it available to a wider audience, because I just think it's a wonderful idea and one that we want to be a part of.
Thank you. Chris, yes, from VACCHO, Victorian Aboriginal Community Controlled Health Organisation. You know, you're the local health provider, Indigenous health provider, community controlled, and you and, sorry, I'm so bad with names. Your CEO?
Jill Gallagher.
Jill, you're here, aren't you? Is that Jill over there? No. No. Okay. Anyway, okay, so you've been here. Tell us what you think, please.
Sure, well, I should first send the apologies of both Jill Gallagher, our CEO, and Louise Lyons, the Director of the Public Health and Research Unit at VACCHO. Two intelligent, strong Koori women, and instead you've got me, a sleep-deprived new dad from Greek and Irish background. I was actually listening to John talk about the history of the NKPIs in the Northern Territory. I've been listening over the last day and a half about sort of externally imposed structures and so forth. And with the NKPIs at the moment, I know when I first started in this role, a lot of at the VACCHO members meetings, there was this discussion around how can we get data from all the ATCHOs that tells a story about what ATCHOs do and like what the benefit that we provide to the community. And so we sort of set out on I guess, a bit of a discovery to try and see what we could do. And we ended up being quite limited to healthcare because in Victoria alone, there are 3 electronic medical record systems used. Anyway, long story short, we've got a data collection system now that gets all of this data in monthly. And we're trying to shift the conversation from NKPIs to something more broad than that. And also, I guess, like drawing inspiration from other people here over the last day and a half, is the next step would be to develop far more useful indicators on the ground. That said, I know that Ian was just talking before about it's an opportunity with COAG targets changing. There is discussion though at the moment with using a certain set of the NKPIs to determine how much funding each ATCHO will receive. So we've got this external data set that has always I guess, directed a far greater sense of attention than it should have, considering what else is going on. And now, out of that subset, we're talking about that will actually have quite a significant impact on how much funding each ATCHO will receive. If you meet 0 to 4 of those targets, you get X amount. If you meet 5 to 7, you get more. And that's obviously going to have structural implications as well, to put it mildly. So that's just one little space, and I think that's really important to talk about here because this is a data for health section, and I know that VACCHO is working in this space, but it's going to take years to develop that further and to develop the indicators that we've been talking about over the last day and a half.
Well, look, you raise, I think, one of the serious problems, the misuse of data, with the government saying, if you don't meet these KPIs, if funding's going to be cut. Well, that's attribution of, cause to a statistical construct, and it's completely wrong. And, there are people here who can tell you why.
They haven't actually made the decision yet, and NATCHO are totally opposed to it. And my gut feeling is it won't happen for all the reasons it shouldn't happen. So it's a proposal. It's come from the top down, from Cabinet, not even from Health, but from Treasury and Finance, saying they looked at these NKPIs and they said, wow, what a goldmine. We'll just fund the services that are doing well, but they're only using Commonwealth funding inputs. So if services have state government money and money from the PHN, so they've got more money, they do better on indicators, they get more money from the Commonwealth. It's really absurd. if there's any reason left in the universe, then it shouldn't happen. And it hasn't happened yet. They haven't made the decision. It's just on the table. It's a threat. It's really, it'd be a major breach of trust with the sector. When we developed the NKPIs, hand on heart, we told everyone they would never be used for funding purposes. They're to be used for quality improvement and at a community level so communities know what's being achieved. They were never meant to be used for funding purposes. But this has come down from the bean counters thinking this is a good idea. But within the sector, we all have to be united on this because there's some elements of the sector who think it's a good idea as well. So some services that are doing really well think, well...
We'll get more money,
Yeah.
so they're going to diss you.
Yeah.
And, it goes completely against the principles of, say, the Grants Commission principles,
Yeah.
of horizontal equalisation,
Yeah.
so that you take into account geography, remoteness, levels of disadvantage. So, if you're a Koori living in, Fitzroy, you have a very high level of advantage. That's not understood, as compared with, a Pinnaby person living in Kintore. So we've only got 5 minutes and I'm talking too much. Sorry. Sorry. I want to hand over to Lyle. The Institute of Urban Indigenous Health is an extremely innovative organisation. Their use of data is innovative. Tell us what you're thinking there, Lyle, please.
So we try to use data for much more than just the bean counting and reporting. So we've got our service, for those of you who don't know. So IUE was set up, I think, in 2009 as an initiative of our 4 member services in the South East Queensland region, which is Camboos, Colwyn, Brisbane Oaks and Ulu, Buribar. So that,
Which are for all Aboriginal community-controlled health services
that covers
in South East Queensland.
Yeah. So we've actually got quite a large, or one of the largest Indigenous populations in Australia. I think at the last census was about 65,000 in the South East Queensland region alone. And so those services, the original idea was that there was competing resources, overlapping populations, so it was better to come together and have a kind of unified approach, and that's sort of where IUE was born out of. Initially as an organisation that's responsible for planning, development and things like that. As it's turned out, we've kind of come into the service delivery space as well, filling in the north of the river in the Moreton region. So we run AIATSIS, which is the Moreton Oaks that covers Deception Bay, Caboolture, all those sort of regions as well. So we're all shared. So in terms of data, the tech side of things, we run off a single cloud-based patient information system, and that allows patients to attend any of our clinics and the records to be shared with consent, obviously, and approval, so they can attend one clinic or attend another clinic, and the records can be brought up for their care to be sort of continuous across services and across the region. Integrated service, we provide a whole heap of allied health, so it's looked at as a one-stop shop. So the patient will come in, get their health check in the primary care setting, and then be referred internally to a number of allied health professions or programs, support programs. And data really underpins all the work we do. So we've got a number of, I got a decent team that works on producing or analysing the data at the back end of the system. So we use this data for planning our services, for identifying gaps. And aside from, I'm from a quant background, so I work with numbers and I enjoy numbers, but I'm a firm believer. I've only come into this job last 4 months. For the last 4.5 years, I was actually down here at Monash working in the Department of General Practice on the Magnet project, which is it's another story, but it's basically a big database of general practice data collected in the inner East Melbourne region. And one of the things you learn is that the quant data only tells half the story, and in terms of interpretation and stuff, you really need that qualitative, that community and the individual stories to back it up and explain what's going on. And so that's what at IUE, which I've been really impressed, is we do a lot of that we do a lot of our own evaluation, so evaluate our own services and programs, but we also use community engagement to get feedback on community needs, and that helps us shape the direction of where we're going in terms of service provisions. So we're working with Brisbane North PHN at the moment on a big community engagement initiative, but we also have our own community engagement that we roll out at our events, all our Deadly Choices events, things like that, where we get community feedback, what the needs are at the ground level. And I think that sort of information that's not usually collected in other sort of medical settings and health settings, I think is a really important part of what IGUI does.
Well, I know, and I think I have permission to talk about at least one of these topics, that the information is used not only, your quantitative data that you're talking about is used not only as the stuff of interpretation, but also in prediction of the need for services.
Yeah.
and analysis of the need for services. And you've mentioned that, but just to make it real for people, one was noticing that in a particular area, most of the newborn babies were being removed from their mothers. The child protection officers were going into the hospital and removing the newborn babies from their mothers. So how did they stop that? They set up a program, but they realised what was happening both from listening to the community and the data. And you put the two together, hello, there's a crisis. And then they respond by setting up a beautiful program. And they've pretty much, I believe, put a stop to that, right?
Yeah. As an example, we're rolling out at the moment the ANFPP program on the south side
What's
of Brisbane.
AFNP?
Sorry, the Nurse Family Practitioner program. I think John mentioned it yesterday.
Yeah.
And part of that, to get that funding, it comes with an RCT that we have to...
RCT?
Randomised controlled trial. Sorry. Sorry.
Come on, Marcia.
That's all right.
Yeah.
Facilitator.
Oh, okay. Yeah, you knew.
But it was one of the first meetings I went to as part of this new role, and the issue of how are there going to be issues with recruiting women, and the point was raised, well, it's common knowledge on the ground that, and at least as soon as like a woman's pregnant, as they're coming towards the birth point, they're quite fearful the docs are going to rock up and take the kids. So being involved in a program like this is sort of reason enough to hopefully stop that from happening, so we won't have an issue with recruitment. Just to touch on that point, yeah.
And then the other one that I'm really impressed by as well is We Say No More, which is an anti-violence campaign run by the community and by kids, and it arises out of clinical data. So an extraordinary number of patients presenting at the clinics showed evidence of being victims of violence. And so out of that arose the We Say No More campaign to stop violence, and it's wonderful.
Yeah, and that's spawned a whole kind of social health program, which is one of our biggest programs in our family wellbeing services. Which is spread right across the region now. So that's a big part of what we do.
So those uses of community, this is what I mean by Indigenous sector data, this is very powerful, isn't it?
Yeah. And it's how you collect it as well. So it's the culturally appropriate ways of collecting this data. So at the moment we've got what they're called, so for an urban sort of yarning sessions, we've got basically it's a kitchen table concept. So you have your most open and frank discussions around the kitchen table at home. So that's how we're approaching our current community engagement, is we're setting up at community events. So at the last Murray Carnival a few weeks back up in Caboolture or Redcliffe, we just set up like a kitchen table type setup, and that was manned by staff, and people were invited to come sit down and just air their views, talk and discuss. And that's going to be rolled out through shopping centres in the region as well, and just to get that community feedback, and are we doing the right thing? Are we targeting the right areas? In terms of our Deadly Choices programs and our education programs, that that sort of feedback is critical as well about shaping where that goes. Yeah.
So we have absolutely run out of time, but I can't close the session without allowing Janet to say something. Perhaps you could sum up for us, Janet. Add whatever you like.
Well, I did want to add something because I wanted to actually, the focus of all of this, of course, has been on the present, has been on acute care, has been on people coming through the door needing help straight away and so on. But your health is a product of your history and your health embodies your history. And so the thing we don't have in Australia across the whole sector is deep longitudinal intergenerational data. And that's where the big health is going internationally. Few countries have it. The Swedes have it. The Montrealers have it. And a few other places. And you have it in WA, thanks to Fiona. If you're to understand how things get better and how things get worse, you have to be able to look at families, communities in place, in time, affected by the larger events around them, affected by changes even in climate, in food supply, in water, in judicial administration, in government, and all of that you can do locally, reconstructing your histories on communities using genealogies which have location in place and time. And James Rose's work in New South Wales is doing that. And we need to do that for all Australia. And that must be and would be controlled by you.
Well, thank you, Janet. Thank you to all the panel members.